My name is Kevin Ewancyha. I'm Chief Medical Officer for Samaritan Health Plans, and I've been with Samaritan 19 years. The first decade was doing full-time family medicine and urgent care on the side, and then I was overseeing our primary care practices. I was a medical officer with the Department of National Defense in Canada, and I was born and raised in Saskatchewan, in case some of you can still hear some of my Canadian dialect. But we moved here 19 years ago and raised our kids here in Corvallis, and they went through the public school system. I have a sophomore at OSU, go Beavs, and it's great that we can be part of the community here with all of you to help support improved health for all of us. The talk I'm going to give today is one on bone health. And you might wonder about bone health. Why that topic? Well, it's because we really want to prevent as much as we can the condition osteoporosis, but it's much more than that. It's what other things we can do to make our bones as strong as they could be to help give us a healthy life as possible. So we're going to go through some of those different discussion options today. Osteoporosis, though, what is it? It's a condition that actually affects 25 million Americans. It's surprising that it's that common, but much of the disease state is often silent, meaning we don't know it's occurring until we have a test to show us that we already have osteoporotic bones. It gives about 1 million broken bones every year in the United States. That's not 1 million over a lifetime, that's cumulative. Every year there's an additional 1 million broken bones due to osteoporosis. And it usually occurs in the spine, or the hip, or the wrist. Why the wrist? It's because when we fall forward, our defense mechanism is to try to catch us, and we'll break our wrist right here in either places. Half of all white women that are age 50 or older can expect to have a bone fracture due to osteoporosis. Now I'm going to point that out. That's not half of all women that will have osteoporosis. That's half of all white women that will actually have a fracture because of osteoporosis. So we're really here to try to prevent fractures as much as possible. Half of men will actually have osteoporosis by the age of 75. And women are more at risk of developing osteoporosis than they are at developing breast cancer. So what do women get annually if they're in the age range where they're still having screening for breast cancer? They get that nice notice from the mammography area saying, "You're due for another mammogram. Please come in and see us." We do a really good job from a system approach to try to screen women effectively for breast cancer. We do not do a good job from a system approach to screen for osteoporosis, and yet it's going to affect women more. And I'm going to show you some data that will show that. Fragility fractures are an epidemic. You'll see on this graph here that breast cancer is right here. This is how many 207,000 women will get breast cancer, and this is all broken out by 500,000 people, 1 million, 1.5 million people, 2 million people, 2.5 million people. You'll see that the risk of stroke is about 795,000 people. Heart attack is a little lower than that, but see what the risk is for fragility fractures. It outperforms almost 10 to 1 with breast cancers. And we're not doing a good job, again, of screening and doing adequate education of our population. So I want you to think about the bone like a cantaloupe. You're at the farmer's market. You go and knock on the cantaloupe to see if it's fresh enough, and the outside part is still usually pretty firm. But what happens when you cut it open and you see all the seeds that are in there and the other type of tissue that's holding all the seeds together? It's very mushy and moist. That's how I want you to think of osteoporosis. You may knock on your bones, and from the outside part, they feel firm, or you might press on them. But it's the screening using a bone mineral density test on the inside part of your bones that's important. So keep thinking of the cantaloupe. We want to make your bones as strong as they potentially can be. This is a diagram showing healthy bone on the left and osteoporotic bone on the right. And in your healthy bone, this is a long bone like a femur. It's your leg bone that's attached to your hip. And you see here that this is the cartilage surface here that interacts with your joints. And then you have the long bone here going to the neck of the bone here. And in an osteoporotic bone, you see all these big spots. That's the lack of dense bone that's present in an osteoporotic bone versus a lot of dense bone laid down here. And it's this zone between the dense bone going from the head of the femur or the hip to the neck of the femur where hip fractures are most common. Another slide shows this, and this is not your vision if you're seeing this a little blurry. It's just the way it came across from the computer when I was making my slides. When we look at normal bone, we see things are very, very dense. There's a lot of white tissue and this area of the bone that has less gaps than this part here. There's much more gaps, and those gaps are occurring because the parts of the bone are less dense. So it's like the gaps have grown in size, but they've really grown in size because the bone surrounding those gaps have decreased. So the trick is trying to keep our bones as dense as possible throughout our lifetime. There's different types of osteoporosis. One called type 1 will affect women just after menopause. And why does that happen? It's because estrogen hormones that are in women actually help protect bone and keep them as dense as possible. But what happens naturally after menopause is those hormones are decreasing. Type 2 occurs in both male and females after the age of 75. And then there's something called idiopathic, meaning we don't know why. But it occurs in women before menopause, so in their 20s, in their 30s, their early 40s, and men prior to age 75. Now there's some medical conditions that I'm going to go through that actually give osteoporosis or thinning of the bones. And there's some other medications that can also do this. So what are the risk factors for osteoporosis? Well, one that we can't change at all is advancing age. It means every year that goes by, we are at risk of losing our bone mass. Previous fractures. If you've had any type of fracture before, what happens if I broke my leg and I'm in my 20s or 30s? Well, I'm not going to be putting my full weight down on that leg for a period of 6 weeks for that leg to mend itself again. That amount of inactivity, not putting weight on our bones, is actually a risk factor for osteoporosis long term. So we do want to remind ourselves, what is one of the best keys to prevention and keeping our bones as healthy as we can keep them is activity each and every day. And I'm seeing a lot of nodding heads. Keeping yourselves active and moving your body each and every day. And we really have to message this to our young kids growing up. Long-term steroid therapy. If people have had rheumatoid conditions where they needed prednisone, which is a steroid, if they are asthmatic and they've needed prednisone to clear the asthma symptoms of their lungs, then you are more at risk of developing osteoporosis than somebody that's never been on steroids. Low body weight. People that weigh less than 127 pounds are more at risk. Family history of hip fracture, more at risk as well. Maybe years ago with your parents, we didn't have a way to screen for osteoporosis, but yet they had a hip fracture. They may have had the hip fracture in the first place because of osteoporosis. So that has to be taken into account, your family history, when we want to effectively screen for osteoporosis. Cigarette smoking. The nicotine and different things in cigarette smoking actually robs our body of calcium, and it is a risk factor for osteoporosis. And then excessive alcohol intake. Anybody know what we define as excess alcohol intake right now? Say more than 2 drinks per day for women, more than 5 drinks per day for men. That is considered excess. Now, Men, that doesn't mean that I want you to go and have 4 or more drinks every day of alcohol just to try to prevent osteoporosis or think that you're safe. But that's our definition of excess alcohol intake. The other types of osteoporosis, and I apologize for those of you in the back, it's going to be hard to see that slide, but all of the handouts are printed out for you so you can follow along. But these other secondary types of osteoporosis are due to eating disorders, not getting enough calories in our body in the first place. Steroid excess, prednisone, I already talked about that steroid. Rheumatoid arthritis, that alone is a risk factor for osteoporosis. And chronic liver or kidney disease, this is where some of the alcohol intake can come in. It does affect both our kidney clearance and our liver clearance. Malabsorption syndromes, that means something in our intestinal tract or our stomach where we're not absorbing the correct vitamins and minerals and nutrients that our bodies need to produce good, healthy bone. Overactive thyroid, not underactive, but if you had something called Hashimoto's disease, Graves' disease, those two conditions gave a lot of extra thyroid hormone in your body that you didn't need, but one of the side effects of that is it breaks down your bones a little quicker than somebody that actually has a normal thyroid. Now, somebody who is on thyroid replacement, so underactive thyroid, and that's actually more common than an overactive thyroid, there is no risk if your TSH is in the normal range. So if your thyroid replacement that you're taking is keeping you in that normal state, then you're not breaking down your bones faster. It's if you're getting too much thyroid hormone from replacement that you could be at risk. So it's very important to talk with your doctor about that. Genetics. Osteoporosis does run in families. We still haven't found a gene, but we know that it's more common in ethnic groups if you're white, if you're Asian, but it's less common in the Black or Latino population. So we still haven't found that gene, but we know that it does exist somewhere. It does increase as we get older. We already talked about that, and it does affect more women than men. 30 to 40% of women. So looking around the room, if we had 10 women, 3 or 4 of them have osteoporosis. Some may know it, but many do not because it's very silent. And then 5 to 15% of men will have osteoporosis. Secondary osteoporosis is about 5 to 10% of the population, both equally in men and women. And that's due to those secondary medical conditions that I talked about. This is a graph showing us our importance to keep our bodies moving as much as we can, and also really stressing to our kids growing up to ensure they have adequate calcium intake from whatever means, adequate vitamin D intake. And here in the Northwest, vitamin D supplementation is extremely important in our cloudy winter days. We don't get enough of it from the sun during the fall, winter, springtime. So we really should be on vitamin D supplementation if we live in the Northwest. But we'll see here, what is our peak age range to get as much bone strength built up in our bodies before we start to get into accelerated age. It's the decade of our 20s. After we hit about age 30 years of age, both men and women see a slow, steady decline in their bone mass. And we can't prevent that. It's just going to happen in all of us. So our message to our young generation growing up is you get as much activity, as much vitamin D and sunshine, as much calcium, as much movement on our muscles and our bones as possible before we get to our 30s. Because after that, we'll see men is here in the top zone, slowly declining, but women here, again, after 30, we start that decline, but it even speeds up more due to menopause. Males don't go through menopause like women do. It's different. Signs and symptoms. What are the signs we might have about osteoporosis? We may have 0 signs at all, but we may have backache. It may be acute or chronic, meaning chronic over 6 months and longer, acute meaning less than 2 weeks. We may have kyphosis. What's kyphosis? I'm going to stand this way for you. It's when we get like that. It's a curvature of the spine forward. What is scoliosis? It's a curvature laterally to one side or another. And that might be some of the symptoms that you've never had before, but then in your 40s, 50s, 60s, you're developing more of a curvature. If you are, and this actually does run in families, but if you are and you've never been screened for osteoporosis, you should be screened. Fractures that weren't due to trauma. So of course we have a slip and a fall. We break a bone because of a fall. That's a fracture due to a trauma. But a fracture to no trauma at all often can happen in our spine, meaning we have what's called a compression fracture. Just the weight of our body and that vertebrae just collapses by half. That usually gives a lot of pain, but in some people, believe it or not, we see it on x-rays that they've had a fracture, but yet we ask them, do you remember any really bad pain? Well, maybe for a day, but it kind of went away. That could have been an osteoporotic compression fracture. We don't see bone deformities in our periphery. So you cannot see your hands, your lower heels, your feet, and think, I think I have osteoporosis. And that's going to be important as we get to some of the screening methodologies that give the most amount of useful information and data for you. But we usually don't get changes in our hands and fingers. We'll get arthritic changes in our hands and our feet, but we won't get osteoporotic changes. And we might see a loss of height. I've lost about a half an inch from when I was 20, 30 years old. It's really, really hard for me to deal with that, but I know that is just part of the normal aging. But if there's been a time where 1 year to the next, or you've been at your doctor's office and they try to do your height and weight pretty regularly, if there was a big change, all of a sudden there was an inch less than the last time that they measured, and you really didn't have pain to any degree, you should get a screen for osteoporosis. So risk factors again, normal aging is a risk factor. But osteoporosis occurs most frequently in those people who didn't achieve that optimal skeletal mass during development, or they lost it very quickly afterwards. So what's that optimal age range again that we can tell our grandkids and our nieces and nephews? 20s. That's their most important decade, up to 20s. So childhood, up to 20s. And after 30, slowly going downhill. Other risk factors, inadequate calcium, whether it's from your food or whether it's from taking different dietary supplements. But also extra phosphate and protein. And there's a lot of phosphates that are in soda. So there can be a link with increased soda intake and a risk for osteoporosis. And inadequate vitamin D intake. We talked about that already being in the Northwest. But the physical risk factors being sedentary, not moving your bodies, and then the social risk factors, alcohol, cigarettes, caffeine, extra caffeine can also be a risk factor. And this we say is more than 2 cups a day. So if you're a person that's 5 to 10 cups a day, well, maybe that is a risk factor. And then the different medical conditions we already talked about. These are iatrogenic risk factors. These are things doctors do. That's what iatrogenic means. And this is steroids, or a doctor keeping your thyroid hormone too high. Chronic heparin. Heparin is a blood thinner. It's one of the blood thinners that we use. And people that are on heparin for long periods of time can lose their bone mass. Some types of chemotherapy. As chemotherapy agents are in our body, they're not specific only for cancer cells. They break down other cells as well, and we have these cells called osteoblasts. These are the cells that form new bone, and those cells can be hindered in chemotherapy. Some diuretics, some water pills, we can actually lose extra calcium through the urine, so that can be a risk factor. Anticonvulsants, these are seizure medications. Radiation therapy is specific for a cancer, but it also affects those osteoblasts that I was talking about, the new bone formers. And then Depo-Provera, that's a hormone, but it's on the other end. You have estrogen and progesterone. Depo-Provera is a progesterone. And so while estrogen is helping your bones and keeping them stronger, Depot shots is a risk factor for osteoporosis. And methotrexate, this is a medication that's used in rheumatoid conditions, and that can be a risk factor as well for osteoporosis. But again, we see in some families where they're just fast bone losers. They lose their bone over decades much quicker than other people, and this is a genetic trait. This is where we see clusters of it in every woman in the family. In 2008, the World Health Organization came up with some type of measure to give a lifetime risk of osteoporosis for people. That's called FRAX. Stands for Fracture Risk Assessment Tool. And all doctors should know about this, but not all doctors use it. So I'm getting back to that system of care. We do good reminders for breast cancer and mammography screening. We don't do a good systemized reminder of using FRAX for a tool. But I'm trying to do my job now and get out in front of our doctors and saying, remember this thing called FRAX? Now when we have electronic medical records, there isn't a reason that it shouldn't be done and then shown there for all physicians to see, inclusive of your specialists. So this I already talked about again. It's just a summary again, reminding you about the risk factors for osteoporosis, the clinical risk factors of rheumatoid arthritis, and then labs. Some people will think, well, can I get a blood test to see if I have osteoporosis? And there are some labs that will show maybe some changes in your calcium levels, but usually not. And if we do a blood count, a complete blood count, that looks at your white blood cells, your red blood cells, your platelets, and you'd think, well, where does our blood cells come from? They come from our bone marrow. And do we think that there's a change with the bone marrow because of the bone that's surrounding it? We don't. And that's why your blood counts, red blood cells, white blood cells, platelets, will usually be normal when you have osteoporosis, even though the bone marrow is right in your bone. It's like the middle of that cantaloupe. That's where your marrow is. Urine calcium levels. If you're losing too much through a diuretic, a water pill, then your calcium levels in your urine might be elevated. But it doesn't show up. If you go to urgent care, your primary care office, and they do just a urine dip to see if you have a UTI or something, calcium won't show up on that. It's a very specific test that has to be ordered by the physician for the lab. Alkaline phosphatase levels. These are one of the levels that are seen in liver enzymes, but they're also increased if the bone is broken down too quickly. So that could be elevated. And then protein levels. If we're malnourished and have lower protein levels, or on the reverse, too high of a protein, as the protein goes through your kidneys, it can sometimes drag some of your calcium with it as well. What will we find with imaging, X-ray? We might find some evidence of osteoporosis that's already there with some X-rays, but it's not a good screening. Bone scan. This is if we have a cancer somewhere in our body, the oncologist may ask for something called a bone scan, and that's to highlight other areas where that cancer may have spread. So it might be in the brain, might be in the lungs, might be in the kidneys, might be in some of the bones, but it's not a good screen for osteoporosis. So that's why if you've had a cancer and have had a bone scan, they would not be able to tell you whether your bones are strong or enough. It will just show where there is a possibility of a secondary spread of that first cancer. The bone mineral density test, or a DEXA. That's the most common type of a scan, and it does scans of your low back, or your forearm, or your upper thigh bone. And DEXA stands for Dual Energy X-ray Absorptiometry. We just call it DEXA. It's easier. That's what a DEXA looks like. It's not an MRI. So there are some people that have heard of friends of theirs going through a DEXA before. And the friend describes, well, I'm laying on something that's flat, and something comes over me and takes pictures, And automatically we assume, oh, that's an MRI. And some people truly have fear of MRIs too, and claustrophobic. So because they've heard that it might be like an MRI, that might be one of the ways that people get scared and nervous about getting a DEXA in the first place. But it is very, very easy and simple, and it's done in clinic settings. We're going to show you a video of one later. So what about these heel ultrasounds? The pharmacy fairs will have them. I've seen them advertised at Bi-Mart, for example. You can pay 99 bucks and get a heel scan, a carotid artery scan, and a blood pressure, or maybe a cholesterol, all for 99 bucks. Is that a good test to do for osteoporosis or not? And they're not very accurate. They're about as accurate as an X-ray. So I might be able to give you a guide, but what we've seen in people that have a heel scan at the pharmacies first, about half of them will be told that they're okay. The other half will need to be tested further with a DEXA scan. So I would say, do you want to do two different tests? One saying you're okay, but you really don't know if you're okay? Or do you want to do just one test that is the best diagnostic test, and that really is DEXA? So I would say, save your money. If you have different copays for your medical benefits, and you're willing to pay a copay for either or test, save your money for the copay for the DEXA scan. It is covered under Medicare. Not all of Medicare plans will cover the bone scan or the heel test because of that error rate that is occurring. So please keep in mind, it's of preference, of course, for you to make that decision with your doctor. But if I ever had to give you a recommendation, I'd say do the DEXA before the heel. And we as Samaritan and Samaritan Health Plans, we don't get any kickbacks from giving that message. This is just being shown from the data alone to support it. So treatment, what do we do? Well, we treat pain if there's a fracture. We want to prevent in decreasing falls. We want to make sure we keep our bodies moving. We have our other guests here that are going to be going through dietary and medications for osteoporosis treatment. So again, keeping in mind that need for exercise and keeping our bodies moving as much as possible. If we are smokers, trying to quit smoking. This is a list of the different pharmaceuticals, and Crystal is going to be going that into more in depth. And then what happens after we get an osteoporotic fracture? Well, about 70% of people after a fracture will stabilize their bones, meaning they increase their bone mass, they're more active again, reducing pain. But this is the key, 20 to 30 people that get an osteoporotic, 20 to 30% of people that get an osteoporotic fracture will lead to chronic care, meaning in-home care, or being in an assisted nursing facility, or often going towards premature death. This is key. This is why we want to screen effectively, why we want to treat effectively. We want to reduce that 20 to 30% of people that need long-term care or die prematurely from a hip fracture. And maybe you've had experience with people in your families where they were doing fine up until a certain time and they had a fall. And then that fall broke their hip. And then that hip maybe was surgical repaired or not, but you could see the ability of them in a health status to do everything that they once did for themselves is impacted dramatically. And what happens after that, if we're placed in an assisted living facility due to a hip fracture that is not healing well on its own, we're more at risk of getting other types of infections from that long-term care facility. We are not moving our bodies like we once used to, and our other chronic diseases that we might have seem to get sped up very, very quickly. And we see an increased death rate because of that. So we want to prevent falls in the first place. And in the handouts that you had, there was a little cartoon where you could go through your home looking at different things that might decrease your risk of falls. But as we age, our balance and mobility does get decreased. Doing an environmental scan, do we need hold bars in the bathrooms? Do we have those nice throw rugs that are still around our floors that are easy to trip on? Do we have cords that we could trip on? There's medications that can cause us to become dizzy. And then we have chronic conditions, alcohol intake that can impact our balance as well. And that might be it. All right. So I was a little over time, and I apologize to our team. And that was because of our initial microphone issues. But I'm going to make sure I stay afterwards to answer any questions that you might have during our lunchtime as well. So thank you very much.